Hi everyone, welcome back to Raw Talk Podcast's COVID Decoded series. I'm Erin, and today I'll be hosting our 7th installment on COVID-19 with a health equity lens. But before we begin, we wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and most recently, the Mississaugas of the Credit River. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we're incredibly grateful to have the opportunity to work on this land. Now, if you're new to Raw Talk Podcast, we are a graduate student-run show about medical science and the people who make it happen. You can check out the description for more information about our show, and you can subscribe and tune in on all of your favorite podcast apps. I'd also like to take this opportunity to thank our incredibly hardworking team behind the series, including Alex, Kat, Richie, and Thamia. We would not have been able to pull this off without each and every one of you. I'm very excited to be joined by our two guests for our discussion today, Dr. Roberta Timothy and Dr. Ceinwen. Dr. Roberta Timothy is an assistant professor in the teaching stream and is the new Director of Health Promotion at the Dalla School of Public Health at the University of Toronto. She specializes in intersectionality and ethics in health work and anti-oppression, anti-colonial approaches to mental health, and has over 30 years of experience in community health on resisting anti-Black racism and intersectional violence strategies. Dr. Timothy is also the co-founder and consultant at Continuing Healing Consultants. Dr. Ceinwen is a new family physician and current medical resident at the University of Toronto's Public Health and Preventive Medicine residency program. Her interest in health equity and population health led her to pursue an undergraduate degree specializing in global health at McMaster University, followed by a medical degree at the University of Ottawa. She'll be starting a Master of Public Health and Epidemiology at the Dalla School of Public Health as part of her ongoing medical training in the fall. And one last note before we begin, I want to quickly remind everyone to send your questions to the live YouTube chat box. We'll be reserving the last 15 minutes today for all of your questions. Okay, now without further ado, let's welcome our guests, Dr. Roberta Timothy and Dr. Ceinwen. Welcome.
Thank you. Thanks for having us, Erin.
Yes, thanks.
How are you both today?
Good. Looking forward to the discussion.
Me too. Yeah. So I thought that we could perhaps start off by getting to know both of you a little bit better. And I know that both of you are very strong advocates for health equity in your respective work and professions. And so perhaps this would help to our viewers to get to know you both a little bit better. So maybe, Ceinwen, I'll turn this one to you first. Can you tell us about a little bit about what motivates you to address and advocate for issues of health equity at the forefront of your work, and what keeps you inspired to continue to do so?
Sure. I got into this work originally because I had a lot of internal motivation around, seeing and getting fed up with issues of injustice in society. And I was drawn to health because initially the whole science thing, but also because you can see those injustices reflected in health. And so focusing on health kind of helps you make people feel better and well-being, and that's great, but also allows you to work on those injustices at kind of this more upstream level. And so that was really reinforced when I got into medicine and started seeing patients, because it became a lot more clear kind of what needed to happen and what people are experiencing around me with the social determinants of health, like all of those living conditions that were leading to them to see me as a family doctor. And I think what got me into public health was just the interdisciplinary aspect of it. Not one sector alone, and certainly not healthcare alone, can be able to do a lot of the work that I wanted to from that higher up level. And so public health, being able to work across sectors, was something that really interested me and continues to be invigorating, because you get to learn about all sorts of things, how planning intersects with health, how different policies in government intersects with health, how just the way that society is set up can be changed from within and the outside, of course. And I think especially just the people in this line of work and who are working on health equity are already super energized and very dedicated. And I think working with those people, it's hard to not be energized about what you're doing because we all have similar goals. And I find it exciting to work with all these different people involved.
Mm-hmm. And I certainly feel that just from both of your energies. I know that both of you are very motivated to do this type of work. And so I also want to thank both of you for joining us today for this discussion. But Roberta, I'm going to turn to you. I want to hear about what motivates you to do the work that you do and what keeps you inspired.
Thank you, Erin. I think first of all, I would say I was born into a movement. And, my location, I come from a working class African descendant of, transatlantic slavery survivor, woman with a disability, mother of two. So I would say that I'm motivated by over like 401 years of active resistance, really, from African, Indigenous, and racialized folks. My elders motivate me, who have done so much work trying to eradicate all forms of anti-Black racism and intersectional violence. Our kids and our youth motivate me. What's happening right now in terms of the fight back and the resisting against anti-Black racism and anti-Indigenous racism locally and globally. My children, the generations to come, they motivate me. The generations unknown. Leaders in the community, known and unknown, motivate me. Programs like this, folks like you who are actively trying to implement change through podcasts and through education. So I get motivated from many areas, and I think my main focus is always on decolonizing and dismantling systems of oppression, and how do we create, inclusive health equity, health empowered places and spaces for all folks. Mm-hmm. So yeah, a lot of things, and everything motivates me that just dismantles violence and creates equity and change, active equity and active change.
Mm-hmm. And I think that I hope that our discussion today will be a step within that direction. And, as you just mentioned, inequities and systemic racism and so many of these issues are very long-standing and very deeply rooted within our systems and our society, and historically and presently impact the outcomes of Black, Indigenous, and underrepresented, marginalized, racialized groups. And I know that there's a lot to unpack, and we're certainly not going to cover that within the hour. But hopefully, I'm wondering if we can start to unpack that a little bit just for our viewers, for people who may not be as familiar. And I think that's actually one of the first steps to building more equitable structures is awareness and understanding and knowledge. So Roberta, maybe you could start us off and give us a little bit of a background on sort of the historical structures that impact our current circumstances.
Right. So that's a huge question.
Yes, I know.
But I think it's an important question. So I think one important thing to note is that, Canada is a white settler colony, right? So Canada has been settled by white settlers, and it was done so through genocide of Indigenous people, and also with the enslavement of African people. So Africans were brought to what's now called Canada, and Indigenous people who were here were not only cultural but also actual physical genocide occurred. And the Indian Act, which is an act that is still governs Indigenous people's lives in Canada, was a way to support the state of Canada, or the myth building of Canada. So I think there's certain policies that people should know. So one policies or processes. One is genocide. One is the transatlantic slave trade. One is the Indian Act, the British North American Act. I'm just going to name some things, and people can go research them.
Yes.
The Code Noir, which was a anti-Black racist policy that governed Africans in Canada, which is now called Canada. It was governed by France at the time. The right to vote, and the history of the right to vote is really important. The 60s Scoop, the Chinese Exclusion Act, Komagatu Maru, Japanese internment camps. These are all racist policies that impacted health equities for African, Indigenous, and racialized folks today. The criminalization of homosexuality until 1969, bathhouse raids in gay bars, the mistreatment of Haitian and Vietnamese boat people in the Canadian context. Missing and murdered Indigenous women and girls. Very critical to understand that the murder and missing of Indigenous women and the violence against Indigenous women is related to the health inequities that we see today. And it continues today, by the way. Bill C-45, the Cannabis Act, the Canadian Mental Health Act, Children's Aid Society. Indigenous and African children are in the largest numbers of children who are in Children's Aid Society, and that directly has to do with anti-Black racism, anti-Indigenous racism. The criminal justice system, also Indigenous and African folks are, the largest numbers of populations who are incarcerated. Educational system, which is really an educational apartheid system that sees Indigenous and African and racialized folks, particularly Indigenous and African folks, not getting through, not being able to sustain education or get education that is without experiencing violence. Housing insecurities, food insecurities, HIV stigma. These are some of the important pieces of understanding of the Canadian history. So policies, practices, and institutions that have impacted health for Indigenous, African, and marginalized populations have to do with some of those policies that I related to. And what it basically has created is an apartheid healthcare system, a system that has doesn't treat everybody equally, that people don't have the same access or the same health results or health outcomes based on race, gender, sexual orientation, age, disability, and the kind of intersectional identity that comes directly from a history of violence, a history of brutality that then has now impacted or continues to impact our communities.
Mm-hmm. Thank you for giving us a really quick overview of so many different factors. And it's, as you can imagine, it's incredibly complex and layered. And to be able to create more equitable structures moving forward, you have to understand where all of those things have come from historically in order to move forward, and also to make solutions in the present. And there are certain terms, and I think that we perhaps take for granted right now within our discussion, but I'm wondering, Ceinwen, if you could help us to just define some of these terms to set us up moving forward, such as intersectionality and positionality. And we know that the intersection of social categorizations and identities that each of us hold can either contribute to privilege or oppression, as we've just heard. So I'm wondering if you could help us define some of these terms.
Yeah. So intersectionality is, I guess, a way of looking at the interconnectedness of different people's social identities, and how that interconnectedness changes their lived experience. And so, for example, my experience of gender as a white woman is going to be different than a racialized woman's experience of gender and their race and their lived experience generally in society. And so then that brings up the point of positionality. What are these social positions? And as you mentioned, each sort of position we hold can bring with it either that privilege or that oppression. So, and it's unearned privilege and it's unearned oppression. These are not things we took for ourselves, they were given to us. And so actually one activity that I went through around positionality that I found was helpful was to take some time to, like maybe even just 3 minutes, to kind of think about your own positions in society, and actually write it down physically. Make a list. Your gender, your able-bodiedness, your race, all of these things that contribute to our experience of in society. And you'll notice that at the end of it, if you compared with a longer list of all of these types of positions, that you're missing some. At least I found that. And it's those positions that you leave off are often the positions of privilege that you're blind to. And as you mentioned, understanding where you are in society and how your position and intersectionality contributes to your own perceptions can really change how you approach things. And we'll get into that also with COVID and responding to COVID.
Mm-hmm. And thank you for raising your own example. And I think that's a really important exercise for all of us to take on moving forward. And so maybe, we'll switch gears now and to talk about health equity or inequities within the context of the current COVID-19 pandemic, as we've kind of set up a nice backdrop for it. And really, the beginning of the public health response to the pandemic was flattening the curve. And we had lots of essential measures put in, such as social distancing, social isolation, quarantining. And the expectation is that, everyone can do that and that it can flatten the curve universally. But what we've seen is that COVID is not the great equalizer. And we've seen sort of a new pandemic of inequality, or not new, but perhaps an exacerbation of the existing pandemic of inequality. So my question, I guess, is how has the pandemic exacerbated the existing health inequities that we've already discussed so far, and contribute to increased risk of COVID-19 for racialized, marginalized, and underrepresented groups? Roberta, maybe I can start off with you.
Yeah, thank you. I just want to say one more thing about intersectionality.
Yes.
I think it's really important to note also intersectionality comes from Black feminist thought and critical race theory, because I think sometimes that's not talked about. And I really think that to understand it is to know the history. And I just want to put that out there. It's critical to understand that history, particularly when we're talking about what we're going to be talking about. So we know that before COVID, I want to go back a little bit. Before COVID, we know that there were health disparities for Indigenous, Black, racialized, marginalized communities. Just want to give a couple examples. Diabetes rates doubled among Black women from 6% to 12%. Black women have a higher risk of developing cardiovascular disease than Black men. Among ethnic communities, Black women have had the most drastic increase in rates of high blood pressure, increasing from 20% in 2001 to 27% in 2012. And the reason I say that, because we've had these health injustices before COVID. So that during a crisis like COVID, of course, we see that this is intensified for African, Indigenous, and racialized folks. But particularly, I want to speak about African folks and what's happening. So one thing that I think is really important to note is that who is susceptible or who are in positions of health inequity in our communities. So we know that precarious workers are one group of people. We know that essential workers are one group of people. We know that migrant workers. We know that people who live in multiple dwellings, so they have more than 3 to 5 people living in their house. We also know that it's people from working class backgrounds, so people who are coming from lower income places and spaces, and these folks are in the majority are Black, right? Black and Indigenous and racialized. But I'll talk about the Black and racialized statistics. And locally, this is locally in the Canadian context, and it's also globally, right? So this is not only a trend, and I think when we look at global health and we look at decolonizing global health, it's important to connect these health disparities, that there are health disparities globally that have health inequities for Indigenous and African and racialized folks, and that what has happened during COVID is that these now have intensified, so that we're seeing higher rates of infection in Black and Indigenous communities in Canada and globally, and that also that there is in the Canadian context, limited statistics, even though we have some new statistics, and we can talk about that a little later on, and I'd like to talk about that. So that the increase, there's an increase in health disparities, an increase in impact that has intensified based on anti-Black racism, based on intersectional violence. And this has caused more, more deaths, more apartheid in housing, more food insecurities, a lot of grief that's happening within the community. People are losing people locally and globally, and also people are dying from non-COVID related medical death. And I'm really, really curious about those stats and what's going to happen regarding the people who are dying from non-COVID related, and what's happening, because we already have a community, I'm talking about the Black community, Indigenous communities, who don't trust the healthcare system because of their experience of violence, and are now not seeking, they weren't seeking, medical advice or supports before, or reduced support, and now because of COVID, they're also seeking less. And my hypothesis is that we're actually seeing more people dying. I can't tell you, I've been to a couple of funerals already for non-COVID related deaths in our community, and I think these numbers are going to increase, and I'm really, really worried about what's going to happen as we continue this COVID pandemic.
Definitely. And I think that mistrust of the healthcare system is also, prevalent in other groups, such as those who are vulnerably or precariously housed. That has already been a pre-existing problem for a long time. And, of course, that is another issue that has been intersecting with risk for COVID as well. Ceinwen, I'm wondering if there are any further thoughts that you'd like to add at this time? Or things that you've also seen within your clinical practice?
Yes, I've seen quite a few things in my clinical practice, and I can talk about that too. But one thing I wanted to touch on, just to add to what Dr. Timothy was saying, is because there are so many groups impacted, how do we break it down and kind of understand why it's happening? And I think Dr. Timothy, got at the source of this. Is there are these underlying health inequities, meaning there are differences in health outcomes between different groups of people that are unfair and systemic in nature. And what we've seen is, this term syndemic comes around a lot, and I think that is a good way of understanding what's happening. There's kind of these underlying issues, disease processes that are going on because of these systems of inequality, and they're happening at the same time that this pandemic is happening, and they're synergistic with each other in their population. So they worked so that COVID-19 is exacerbated, and these underlying inequalities are exacerbated. And one of the ways to think about that, why are we seeing more infections of COVID-19? Dr. Timothy spoke to some of what we call the social determinants of health, those living conditions that are already different and already concentrated in these racialized groups, in groups that are, in homeless individuals, in individuals who are unemployed. There's a lot of the same concentrations of these challenges with social determinants of health already. But if you kind of think about it, there's different levels of susceptibility and likelihood of disease severity. If you already have poor health, like Dr. Timothy mentions, these groups already have underlying poor health because of racism, because of colonialism, because of all of these systems of inequality changing the way that their lives are set up in society. And then you have different levels of exposure. So that's things like, are you going to be able to clean your hands and get access to disinfectants and be able to take shelter to isolate, and be able to take time off work? Are there safety nets for that and good standards of employment for that? Those are also things that are concentrated amongst groups of people who are oppressed in society. And then there's, once you get COVID-19, different levels of if you're going to be treated appropriately, right? Are you going to be notified properly? Are you going to be, because many of these people who are getting a lot of COVID-19 infections may be undocumented and not be able to access the portal that we've set up that you can only access if you have a health card. And are you going to have access, or are you going to have enough trust in the healthcare system to access healthcare to be able to be treated appropriately? And again, especially with farm workers, there's so much hesitance that we've seen to speak to public health, to speak to people in positions of power for fear, and because of that mistrust about what could happen to them. And then, of course, just those systems of inequality that are seen once you've accessed healthcare, just differential treatment of individuals within the healthcare system. And so by breaking it down that way, different levels of exposure, different levels of susceptibility and severe disease, and different levels of the way you're treated after the disease, you can see very clearly how all of these systems of inequality that are underlying our society are contributing to exacerbation of COVID-19 and why they're being concentrated in these groups who are oppressed.
Thank you so much for breaking down those systems of inequality so succinctly and so clearly for all of us. And I'm wondering, just circling back to the earlier question about how it's being impacted on your clinical practice as a physician, I'm wondering if you have any things to share.
Yeah, so I was just finishing up my family medicine residency until the end of June. And so within that time, as part of our residency, we go from different parts of the healthcare system to be able to get different learning experiences and training. And so I was, during that time, I was redeployed to the hospital to look after patients who were diagnosed with COVID-19 and admitted to the hospital. And then I was deployed to public health unit as an outbreak investigator. So I was liaising and managing long-term care and group home outbreaks. And I was working directly with healthcare workers who were working in these outbreak settings and the directors of care who are responsible for helping manage these. And then after that, I was deployed to the emergency department where they had set up temporary shelters for homeless individuals who basically were turned away from shelters because they had some symptom or other that was consistent with COVID-19, and they needed a place to be able to stay while they were waiting their test result. And so they turned the emergency department into these temporary shelters, and I was rounding on these patients. And then after that, working in a community health center that primarily looks after racialized women. And so in all of these different settings, I've seen a lot of things, but I think if I had to break it down again, it would be, the impacts of COVID-19 itself, looking after the patients who had COVID-19, and they tended to be older patients already with underlying illnesses. I was seeing a lot of the unintended consequences of the public health measures themselves. People who rely on their independence to be able to leave and get groceries and go for walks to manage their chronic illnesses. And these were things that they weren't able to do. And a lot of people who were really isolated and their support system that they would normally have was not there. And so that leads to the final thing, which is a lot of exacerbations of mental illness and chronic diseases. I can't tell you the amount of people who have diabetes I saw that was controlled before COVID-19, and they were experiencing just poor control of their diabetes, same with high blood pressure. And then, of course, all of the anxiety and depression that came from both COVID-19 and fears, but also all of the unintended consequences of those public health measures. So, yeah, I saw quite a bit firsthand what people were experiencing.
Mm-hmm. And that definitely brings us back to, Roberta, what you were mentioning earlier in terms of what we might expect to see moving forward in terms of the longer term impacts of COVID-19, not only on COVID-19 cases, but on all the other health outcomes of people in our communities. And also related, which is the mental health impact of COVID-19 on people within our communities. I know that you also practice as a psychotherapist. I'm wondering how COVID-19 has shaped your experience as a clinician during this time.
Right. Just to add, I think, to Dr. Pope's answers, increased anxiety, increased depression, what people call post-traumatic stress, which is sometimes just traumatic stress, depending on if you're having, continued trauma from many other spaces. I know people who are undocumented, who are living with chronic illness, who now don't have employment anymore based on COVID, and no longer have money to pay for medications, particularly HIV medications, or to for work. And there's been a kind of silent mental health crisis that's not really talked about, particularly for undocumented. And I just wanted to mention that. But also, in terms of gender violence, women abuse, child abuse. There's not only has it increased, and it always is here. We can see in the media reports of women being murdered still, and children being murdered within this crisis, which was it was like that before, but not getting the supports. I think as a psychotherapist, particularly who specializes in anti-oppression psychotherapy, the need is so overwhelming. Like, I can't tell you the need for mental health support therapists. We don't have the funding. So we need the funding, more funding for, particularly mental health, based on not only the impact of COVID, but the impact of increased anti-Black racism, and intersectional violence. The need in the community to deal with grief, as I said earlier. People are dying. I've gone to so many funerals. There's many people who are not able to say goodbye to their loved ones as a direct result based on the COVID restrictions. So the mental health implications are varied. We need more funding, particularly for racialized folks, for counseling and mental health. We need to also look outside of the box of psychiatry. I'm not saying that there's not some psychiatry needs, but we need to look at mental health supports and how we can, provide people some of those resources and sources. Training of mental health practitioners that are able to work from an anti-oppression or decolonizing process. So, the work has increased. I wish I could take every person, called me or wants, and I can't. A lot of referring going on, but even with the referrals, everybody's overwhelmed. It's a really overwhelming experience, and I think it's going to increase, particularly if there's going to be a second wave of COVID-19 in the fall. We're hoping that something magically disappears, but it looks like it won't be, and that increase of mental health. And I also want to say the impact. I am fearful of the impact in terms of suicidality, and it being not only the isolation, which is one big thing, but also dealing with the amount of death and distress. I think that the suicidality prevention work, particularly from an anti-oppression perspective, needs to be looked at.
And thank you for raising that. And for just our viewers out there right now listening, we also had our third episode of the COVID Decoded series was hosted by me with Don Alexander from CAMH, as well as Dr. Rima Stara from UHN. And we talked specifically and had a longer discussion about the mental health impacts of the pandemic and the need for culturally appropriate and sensitive care and mental health, and also mental health services for healthcare workers during this time. And I think that all of these things are so important. And so thank you for raising these issues again. And maybe bringing it back to something that we also discussed a little bit earlier, was the collection of race-based and socio-demographic data. And since the beginning of the pandemic, there have been increasing calls and advocacy for the collection of this data. And finally in May of 2020, Toronto started collecting this data, and actually last week the report was released from the City of Toronto and Toronto Public Health. I'm wondering, what is the importance of collecting race-based and socio-demographic data? Why do we need this data?
Right. Me? Are you talking?
Sure.
Yep. So, the fight for race and socio-demographic data is a fight that started again before COVID, right? Mm-hmm. We wanted to know what's happening within the community. We know that there's a lot of experience of health violence. We wanted the numbers. We want to have a quantitative, kind of project about the numbers of what was happening. I do want to say that, Dr. David Williams on April 30th, the Ontario Chief Medical Office denied the importance of collecting race-based data. And it's important because we talk about the mistrust. And when we continue the conversation to what's next, we have to debunk and be responsible and accountable for what goes on. And that still hasn't happened. I'm really happy that we have some data. That's great that we have data now. And the data, unfortunately, states what we have been saying. And I'm saying we as, Black, Indigenous, and racialized leaders in this community who've been doing the work. And, there's a Black health leaders wrote a letter. Dr. Eileen Davila in April, she talked about the importance of collecting data. But I also want to say is what happens with the data is critical, and who collects it is important. So having, Black health researchers, Indigenous health researchers, people who do anti-oppression work need to be part of the team that's collecting this data. And it needs to be done to create interventions and programs and give resources to programs that are already doing really amazing work to support, racialized populations. So we don't want the data to be collected by, people who have no idea what to do with it, put it that way. We don't want the data to be a surveillance piece. We're surveilled on a daily basis by police and other government systems. We want the data to be able to do real active change work. And it needs to be done by people who are experiencing the violence, and people who have done research in this area, people who already know how to do amazing programming, right? And we want the data to the data is used to show what we already know, that there's disparities, and hopefully, can create programs that can change disparities, including responsibility and accountability from the government. Mm-hmm. The government needs to be accountable for health disparities and public health disparities in this province, and to change. So the data should be able to be used to do so. So it's not data for data. Don't collect data for data. We're collecting data to create, equitable change and health equity programs for people who have been exploited and violated within the system.
Definitely. And thank you for linking the collection of data to inform change and intervention moving forward, and not just stopping it at data. Ceinwen, I'm wondering if you have anything else to add in terms of the importance of collecting this data and what we can do moving forward.
Yeah, I would echo everything that Dr. Timothy said. I think there's not too much to add. It's just one of those things where, people know what's happening to them, but we need those numbers to be able to really bring it to the forefront of the change makers and decision makers. And it's really a backbone of, at least in the field of public health, to be able to inform our programming and policy making. But as Dr. Timothy mentioned, it has to be done in an appropriate and culturally safe way. The more that I learn about public health and the history and all those acts and everything that Dr. Timothy mentioned earlier, the more I've at least aimed to understand how public health as a field, and of course government, has contributed in the past to those systems of inequality through inappropriate collection of data. And it would be easy to collect data and not do anything with it, and it would be easy to collect data and present it and interpret it in a way so as to further pathologize groups, or to even use it against groups to say that, we need more policing in a certain area, which is what we've seen in COVID-19. And so there are quite a few excellent resources out there on how to appropriately collect data. And one of the important things in all of those guidelines is to connect with the groups whose data you're collecting, because they're the ones who are going to be able to speak to how to collect it appropriately in a culturally safe way, how to store it properly to protect these individuals, how to disseminate it so that the correct messages are going along with it, and to use it to inform programming, like Dr. Timothy mentioned, that will actually do good. And will go back to the community and to the people who gave that data in the first place. So, the Canadian Public Health Association did release guidelines on how to do this properly. CIHI has good toolkits on how to do this properly. The Upstream Lab and community health centers across Toronto have already done this. Many community groups have already done this. So this is something that I think moving forward, it's just a matter of setting up those mechanisms to ensure there's appropriate community engagement on this. And once that happens, to set up the process so that this can be done on a moving forward basis instead of in a reactive way like we've had to do during COVID-19.
Mm-hmm. And I think both of your words and opinions about all that we've discussed so far, and also the importance of collecting race-based and socio-demographic data in a culturally appropriate and safe way. So I'm wondering, after all of this, how can we use all of this data and all of this information to move forward, to promote an equitable public health response to protect and keep all of our communities safe? Ceinwen, perhaps I can turn to you first. I know that you've been doing some work recently around equity-informed public health responses in the pandemic.
Yeah, so what I've been working on, I have been working at a local public health unit. And so what I can say is across Canada and across the world is we're at this phase now where we're trying to understand what has happened during COVID-19 and using those lessons learned to be able to plan for the future. And I think one of the important things with the data is, yes, it has helped us to understand quantitatively which groups have been more impacted, and therefore we need more resources and orientation to. But it's not the only part of the picture. If I was to create an analogy towards medicine, like you see a patient, if they tell you they have abdominal pain, you don't just say, okay, I can help you and come up with a plan based only on that, or only get tests and not ask about, the quality of the pain, where the pain is, how long it's been going on, what factors, what other associated symptoms do you have, what's the physical exam like. You have to look at the whole picture, and the data is just one piece of that. So like I said, what we've been trying to do is get more of that qualitative work done as well, to be able to understand how to put the data in place in context, and then identify some of those mechanisms that I was mentioning, not just for data management moving forward, but for community engagement moving forward. So I think the first step is not just to get the data, but also to be able to understand it and put it in context. And then after that, you can be able to kind of develop better interventions, or reorient your interventions.
Mm-hmm. And definitely the inclusion of qualitative components to the quantitative data is so important, because, of course, the collection of data can be useful in telling a particular story, but actual human stories are lost within the data. So I think definitely rounding it out is super important moving forward. Roberta, I'm wondering if you have anything else to add in terms of how all of this that we know so far can inform and promote a more equitable public health response moving forward.
Right. I think that it's important to, and we said this earlier, but I just want to say it again, recognize the unethical relations that exist between the Canadian state and racialized populations, government and public health and media. We need to understand these pieces, and within public health, we need to understand this history. I think that we need to make ethical decisions that support the health and safety of marginalized populations, and not further hindering them. So this kind of earlier focus on ventilator allocation, I was really touched when a 65-year-old, Black woman told me, about like, hey, you know, when I go there, because, you know, the person's dealing with diabetes, when I get COVID, that was their kind of, you know, story that, will I be, and there's not ventilators, will I get one? And I probably won't. And I say that it's not a focus on ventilation, but to focus on how to deal with, how to actually not be racist and not be problematic. Like, it's really critical to do that, to understand the impact of COVID-19 on our community's health and commit to implementing change continuously at a program and institutional level. Um, to listen and practice empathy with, you know, within our communities, with our colleagues, with our patients who are dealing with the impact of health violence. I can't tell you that dealing with COVID and dealing with anti-Black racism and all of the other intersectional violence has made it a real intensified time. And, you know, in our own working environments, like to come to meetings, Zoom meetings, and not to be, not to be even empathized, not to be considered, what the triple impact that this has had on Black, Indigenous, and racialized folk is a problem. So if you're, you know, you're in your workplaces, you're in your communities, think about the people who are being impacted gravely within this context, and rethink how you're going to act. Unlearn and challenge what you think you know. The surveillance of Black folks and Indigenous folks by police need to be challenged, because it's something that is preventing from people from leaving their house. It's something that is creating continued structural violence, and it does impact our health and our health access. So policing and looking at how to change that is really critical. Decolonizing your ideologies and practices are also really important. It's something I always say. How do you change yourself? We have to change the structural system, but we have to also change ourselves. So what is your accountability for the next steps? The last thing I want to say is in terms of vaccines, just because there's a whole conversation about vaccines. I know we didn't get into it today, but looking and understanding historical and current day health inequities, we really have to unpack what happens with vaccines. And that conversation needs to happen now. Based on scientific racism, the whole history of eugenics within science and Black and racialized communities, we really need to look at how is that going to be taken up, and how is that going to affect and impact health disparities, and hopefully create health equity within the next steps of COVID. So I just want to put that out there.
And thank you for raising that at the end. So perhaps we could switch over to audience questions. We have a couple here. Let's see. So the first question here is, how should public health go about improving trust with marginalized communities? What could improving community relations look like? Does anyone want to start?
I can start with some initial thoughts, but then I'd be really interested to hear Dr. Timothy's thoughts as well. I think, you know, we have a lot of work to do on the trust aspect because of how long and bad the history has been between the government agencies, organizations, institutions, including the field of public health. And so undoing that is going to take a lot of work beyond just good intentions. And so the first step is an internal reflection and is an understanding of how, you know, for example, myself, I've done my schooling, I've done my training in medicine, I've been raised within primarily white privileged environments, curriculums that were created by white privileged folk, and in institutions that were set up by white privileged folk with the European settler lens. And so all of what I perceive to be true comes from those institutions. And so you have to first start with your own reflection and your own unlearning of those perceptions to be able to learn anew. And then from there, understanding how you can be accountable and how you can be transparent with the community that you're trying to serve. In public health, it's interesting because its goals are about population health. And so its goals, you would think, are very well aligned to be able to do this equity work. But because of a lot of those historical pieces and the way it's been set up, it does take a lot of that reflection on an institutional level, as well as the personal, to be able to unlearn that institutional piece as well. Oh no, we lost Dr. Timothy. But I'll just add then, so reflecting, unlearning at the personal level, at the institutional and organizational level, and then reaching out to the community and listening to them, but not just listening, incorporating and being accountable to things. And I think only there the relationship will grow and hopefully will become better over time. I don't think it'll change overnight to be able to build that trust.
Yeah, definitely. I think it's going to take a long time, but I think all of the points that you just mentioned with regards to internal accountability and then, of course, institutional, and then definitely working with communities. I know we touched on that a little bit earlier, but work needs to be led by leaders and members of Black, Indigenous, racialized, and marginalized groups and communities, and that's a really important piece. Maybe we'll move on to the next question, just as we're trying to get her back online. So the second question here is, what can public health units do to address the disparities while balancing active pandemic activity efforts prior or in anticipation for a second wave? That's a big question, eh?
Yeah, and I mean, it's not even that it's a big question, it is the question on a lot of the public health units' agendas right now. It's actually, I just had a meeting today about how at the health unit I'm working at, there are all of these lessons learned coming together from a planning perspective for a second wave for the COVID-19 response. And a lessons learned summary of the equity response for planning for a second wave. And that's what I'm working on. And, part of what we have had to recognize is we did have to react really fast during that first wave. And now is the time to do all this planning. And hopefully what it means is that we're able to achieve a bit of a better balance moving forward now that we have a bit more breathing room. And maybe it's helpful for folks to kind of understand there are these kind of these 5 different phases to pandemic preparedness and response. So there's prevention and mitigation and preparedness, response, and then recovery. And so we're kind of bordering this recovery, response, prevention all at once. And I think it's just important to go back to key principles of how to incorporate health equity work in a public health response when we're doing our active management of COVID-19.
Definitely. Hi, Dr. Timothy. We got
Hi,
you back
sorry.
online.
Sorry about that technical difficulty.
That's okay.
I know you were talking about the question of what we do in terms of public health. And so I don't know all of what Dr. Pope said, but I know there were amazing things said. What I would add, or maybe I might be repeating, who knows?
That's okay.
I think that, we need people who look like myself. We need Black racialized folks in positions of power in public health. We need people, and not just who look like myself, but who have an analysis of anti-oppression and decolonizing health perspectives, who can help support the leadership needed to really decolonize, public health, right? And for active allies who are, also decolonizing their own practices, as Dr. Pope has said that she's doing in her own practice. we also want you to be a part of this process. But I think the leadership change is critical. Changing that power dynamic and changing, giving groups that have been marginalized and treated violently access to power. And within that context, I think it's the heterogeneousness of our community. So we're not looking at just one aspect. We're really looking at incorporating, a lens obviously on race, on gender identity, on sexual orientation, on age, on disability, on refugee status, on education, on undocumented, all of these, I'm probably missing some other ones, but other religion, spirituality, and how that connects to health. So really looking at rethinking how we do public health, number one. This dichotomy between academy and community needs to be separated. I come from the community. I work in the academy. I'm from the community. So the work that we do has to be integrated in our community and reflected in every aspect that we are doing. Our curriculum needs to be decolonized. I know in the health promotion program, a part of my work here as a new director of health promotions is to decolonize the curriculum and start to have an anti-oppression lens in terms of how we're training, public health practitioners. How do we train our doctors who we already started seeing all these programs now, having Indigenous and Black doctors, which is great. It's wonderful. But what are we training these doctors? How do we train these doctors to do health equity and anti-oppression based work? How do we look at medicine differently? How do we challenge the Western notion of medicine? There's so many different notions of medicine and systems that are out there, really, that we call alternative, which are really, these are centered systems that have, worked for thousands of years. What can we incorporate, and how can we incorporate the change and equity through these lenses? I also want to say something about granting for research. I can tell you for Black-led research grants, it's a real anti-Black racist experience, put it that way. So we need funders to actually fund, particularly, racialized, but I'm talking about Black-led research by Black-led researchers. That needs to happen. We have Indigenous health programs that actually have funding now based on anti-Indigenous racism. We need to do the same thing for Black communities or African communities. Challenge the CHR to do an anti-oppression audit, and to be responsible and accountable for not giving Black-led researchers an opportunity to research our communities. We're like, hey, there's no data, there's no research, but we're not gonna give them that. Gosh, there's so many other things that I could say. I think this is an opportunity right now during COVID. The pain is real, the mistrust is real, but also the resistance and the hope is real. And I think we can do this, but we have to continue to think differently, think outside of that box. We've got to be accountable for historical and current day traumas and dramas, as I like to say, and look towards the future with changing the systems that create this violence and really create health equity paths. Resources are needed. Give us resources. Again, I'm always about resources because people are like, hey, these are really good ideas, et cetera, et cetera. Give us money. I have to say that I'm heading a Black Health Research COVID project at Dalla, Lana. And, they have supported the project. Use these big universities, these big public health units and schools and education systems. Give us the resources and we will do the work and show that you're really a part of the healing, the healing aspects of what we want.
Did we lose her again? Okay. But actually, she just stole my final question that I was going to pose, which was, how can we really use this as an opportunity to create sustainable change? And I think Dr. Timothy raised so many important points to consider. And I'm wondering, Ceinwen, do you have any final words or thoughts that you'd like to share?
Yeah, I think just ending off on a note of hope is really important. Change has happened and will continue to happen. And so long as we capitalize on all of the really amazing things that have brought people together during COVID and have supported, starting to put a lot of these mechanisms in place to support, more change and leverage this change moving forward. I think that's really important. And just recognizing that there there has been change and there will be
more
forward.
Yes.
Yeah.
So perhaps we can finish off the discussion here. Thank you so much, Dr. Pope and Dr. Timothy, for joining us today. And thank you all, viewers, for listening today. We hope you learned something. We'd love to hear your feedback about the COVID Decoded series, so please find a survey link in the description. And we hope to see you again next Thursday, August 13th at 3 p.m. for our 8th and final episode on immunity with Dr. David Naylor, hosted by Grace. We'd also like to thank our Pillar Affinity sponsors, TD Insurance and MBNA. This series would not be possible without their support. Check out the link in the description below to learn about preferred insurance rates and credit card rewards for U of T alumni. We're sadly nearing the end of our COVID Decoded series with only one more to go. But if you haven't had the chance to watch our last 6 episodes, you can check them out here on our YouTube channel. We've covered a broad range of topics like the virology, epidemiology and modeling, mental health impact, public health policy, testing, and the intersections with the climate crisis. You can also follow us on Instagram, where we're sharing stories from frontline workers during the pandemic within and beyond healthcare. Finally, support the show by using our Amazon affiliate link in the video description. Thanks for tuning in, and until next time, keep it raw.